Hello, everyone. May I have your attention? Good afternoon, everyone. Welcome to UTS. Welcome to Faculty of Engineering and IT, and welcome to the New South Wales CVRN Rising Star Seminar 2025. This is the first 2025 seminar, Advancing Cardiovascular Medicine, Exercise, Nutrition, and Biotechnology Breakthroughs. I would like to acknowledge the traditional owners of and the custodians of the lands on which we are meeting today, the lands of the Gadigal people of the Eora Nation. I would also like to acknowledge the lands on which our online attendees are joining from today. We pay our respect to all the elders, past, present, and emerging. Before we get started, I want to introduce a little bit about the CVRN, the Cardiovascular Research Network. So the CVRN was established in 2005 to strengthen, facilitate, and promote cardiovascular research in New South Wales through collaboration. We do this by developing and support strategic events and opportunities to enhance research capacity, with a particular focus on early and mid-career researchers. And currently, all the major research institutions and universities in New South Wales are member organizations of CVRN. And this includes all the New South Wales local health districts. The CVRN currently has more than 650 members across the research spectrum, from basic to public health sectors. And people are investigating all aspects of cardiovascular disease, including stroke, diabetes, kidney disease, and etc. And the CVRN actually is founded by the New South Wales Health and organization member fees and hosted and supported by the Heart Foundation. We have an executive committee that drives the strategic direction, and a Rising Star subcommittee responsible for developing and driving events and opportunities for the EMCRs. And this committee is co-chaired by Dr. Addison Gibson, who is here today, and also Professor Jimmy Wendberger. And this is like our first committee meeting this year. And if you want to join us, please send us like a message. We are welcome everyone to join us for the CVRN and also our Rising Star committee. And today we will have 5 fantastic speakers, including 3 EMCRs and 2 PhD students. Our EMCRs will be presenting for 10 minutes, and PhD students will be presenting for 3 minutes, and each talk will be followed by Q&A. So you're welcome to ask questions in the room or raise your hand in the Zoom's meeting with the Q&A function. So I would like to introduce our first speaker today, Dr. Emily Yang. Emily is a research support program fellow in Healthy and Aging at NICM Health Research Institute, Western Sydney University. Her research focuses on Tai Chi-based interventions for chronic disease prevention and management, particularly Tai Chi for heart and mental health. Dr. Yang has published over 80 peer-reviewed research papers. She's also an experienced Tai Chi instructor, advancing evidence-based practice through research, teaching, and community engagement. Today, Dr. Yang will be talking about Tai Chi as a promising exercise training in community-based cardiac rehabilitation. Welcome, Dr. Yang. Stage is yours.
Thank you. Hello, everyone. Nice to meet you all in person and virtually. And I'm Dr. Emily Yang from Ming Health Research Institute, Western Sydney University. And I'm also a Tai Chi master with 19 years experience. So today I want to share with you my research on Tai Chi as a promising exercise training in community-based cardiac rehabilitation. So cardiovascular disease still remains a major public health issue, and exercise-based cardiac rehabilitation is effective and important for secondary prevention. However, the participation rate is still low, especially among the culturally and linguistically diverse populations, including Chinese migrants. In addition, traditional cardiac rehabilitation programs still follow the outdated care models from 1980s and 90s and focus on the subacute phase, often overlooking the long-term cardiovascular health. So more sustainable, accessible, community-based cardiac rehabilitation approaches are needed. Tai Chi is a promising community-based cardiac rehabilitation program. Tai Chi is a mind-body exercise, which is considered as low to moderate impact. And the practice doesn't need complex venue or facilities, and it is adaptable to different age groups, including those with limited mobility and limited exercise capacity. So makes it, and it also can be practiced in person or alone. So makes it an enjoyable and accessible exercise option. And early evidence has already shown the safety and health benefits of Tai Chi as a cardiac rehabilitation exercise training component. However, my previous 6-month reviews and overview of 6-month reviews have shown that more higher quality and larger scale evidence is still needed. So to address those gaps, my team, we have proposed a cardiac rehabilitation program to incorporate health education via text messaging, shared medical appointment as a group consultation, and Tai Chi as an exercise. To make sure our program suits the needs of patients and also considering their preference, including both end users and our major stakeholders, we use co-design approach to co-design this program. So we did virtual focus group with 12 patients from Chinese background, and we conduct those in Mandarin, and each runs 1.5 hours. And we also did virtual interview with 10 healthcare practitioners and Tai Chi instructors in English. Each session runs 30 minutes. And we also do translation from English to Chinese text messaging and do community survey to get feedback from patients to finalize the text messages. And we received feedback from 21 participants. And the patients from the focus group, majority were male participants from mainland China and speak Mandarin at home and retired. Participants for interview were majority born in Australia, speak English at home, and with a wide range of education levels, employed in full time. We identified the major barriers, including lack of awareness of cardiac rehabilitation, lack of referral, and social isolation. For example, Charlie is a 65-year-old Chinese migrant in Australia. He had done 2 stent surgery. However, he never heard of cardiac rehabilitation before, and he lives alone, suffer from social isolation. And other barriers are like language barriers. Some patients refer, but they never attend. And also also other barriers include limited mobility and limited knowledge about cardiovascular risk factors. So addressing those barriers, needs, and their preference, we finally developed this culturally sensitive and community-based cardiac rehabilitation program, including shared medical appointment. We designed it as one-off, run it virtually to improve access, and run it after regular business hours. And Tai Chi twice per week, also virtually run for 24 weeks. And health education, we use text messaging, 4 text messages per week for 24 weeks. And we tested the feasibility, effectiveness, and cost effectiveness of this program in a pilot trial. It is a 24-week pilot randomized control trial, including Chinese migrants with stent and bypass surgery, comparing Tai Chi-based cardiac rehabilitation versus the witnessed control groups. We measured the safety, the cardiovascular function, physical capacity, physical activities, self-efficacy, social supports, and psychological well-being outcomes and baseline 12 weeks and 24 weeks. We also recorded the retention, safety, and measured the satisfaction in the end of this study. Our preliminary results show that the target-based cardiac rehabilitation program significantly improved their physical capacity measured by 7 days walking distance and 6-minute walking test, and improved their psychological well-being, including stress, anxiety, and depression, measured by the DAS scale. So we faced some challenges during the process, and we learned lessons from it. And we plan to refine the study design for future research. For recruitment, we actually didn't meet the target to recruit 24 patients within six months. We recruited 21 in total. However, 89% of the patients who expressed interest to join this study were eligible to complete the baseline assessment. And we received high retention. 86% of participants completed the half-year cardiac rehabilitation program. Because the intervention is delivered all remotely, when we did the satisfaction feedback in the end, participants expressed that they would like to incorporate some in-person sessions. For remote data collection, we also face some challenges because we provide online training for participants to how to use the app to collect with the facilities we use for data collection. And 2 patients withdraw before the baseline assessment due to they think it's too complex for them. So due to this, we refined the design to add the on-site visit and home visit. What we worked well, I think the co-design process can help future researchers to help customize their program for patients. And we also, I think the pilot study really helped us to refine the study design for future research. We would like to incorporate their feedbacks into the design, like both virtual session and in-person sessions, and also provide if we are funded, we will provide an iPad with like the application installed well and IT support for patients. So our next step will do a fully powered randomized control trials. I really like to acknowledge the contribution from my research team, including to cardiologist Professor Professor Clara Chong, and also my colleagues in the ECOM Health Research Institute and our health economist, because we would like to also test the cost effectiveness components in the program. I'm also very grateful for the participants, healthcare practitioners, session masters for their involvement and support in this program, and students and research assistants for their dedicated contribution for the recruitment and data collection. I'm grateful for the 2 fellowships from Western Sydney University that makes this project possible. Thank you very much.
Maria, are you going to watch out online question?
Yeah, we don't have any.
Yeah, we'll take questions from the first. Yeah, please.
I just have a quick question around sort of the Tai Chi, how it was done virtually, but participants sort of said that they would like it sort of more in person. Did you get a sense of whether or not when they were doing it virtually, they were doing it within the home, or were they doing it outside? Like, was there sort of any indication of whether that worked, or even if they had enough space to do it inside if they were doing it?
Yeah, thank you. That's a very good question. So for virtually, we encourage people to practice at home because they need to use the facilities, and we also make sure they do it safely. Like we will watch the space and make sure the environment is good for practice. And for in person, we encourage to do like outdoor, which is like in the green area, and so they can feel the connection with the nature. And also, of course, the ground will be flat, not slope. So make sure they do it like keep balance. But if the weather is not allowed, they can do indoor. So Tai Chi is really flexible to do both indoor, outdoor, actually no very strict requirement for the venue. Thank you.
Yeah, please.
Yeah. This is a great study, great way to educate a whole population. I just wanted to ask, what level of exercise have these participants been experienced prior to this study? Are these just from your general field?
Yeah, thank you. We set our requirements and patients do not have Tai Chi experience within the past 3 months. We actually, in the beginning, we included 2 patients who had some experience in the past. However, those 2 patients withdraw. So I think recruit people with their beginner will be better to understand Tai Chi's benefits. Thank you. And also we designed the program which is easy to start and they can progress. They can progress following the instruction based on what they have gained and also the improvement with their physical capacity. Thank you.
Cool. Any other quick question? Okay, cool. Let's thank Dr. Andy.
Thank you.
For the great presentation. Dr. Gumuskaya is a senior lecturer at the Western Sydney University School of Nursing and Midwifery. Oya completed a master's and a PhD in the surgical nursing while developing her career from clinical experience to research and education in Australia and Turkey, collaborating internationally in research, education, and nursing leadership. Her passion for perioperative care excellence drove her research focus to implementation science and de-implementing unwarranted practice.
Thank you.
Stage is yours. She's going to talk about reduced
Preoperative fasting. Thank you, Peter. Thanks, everyone. I am going to talk about procedural fasting because it's coming here. I wanted to draw attention to other procedures, not just surgery. So preoperative fasting, what do we know? What are the recommendations? But what happens in the actual day-to-day clinical life in surgical units? What are we doing in our research? What directive we're taking? And what barriers we faced quickly? I'm going to squeeze all that. So there was only one single study from 1946 with 44,000 patients, 66 aspirated, and there were 2 deaths. And since then, we were like, okay, no more eating or drinking before surgery. That's how nil by mouth or NPO, the nil per os, the Latin abbreviation, started. And it still continues to persist. Over the last 20 years, evidence emerged and we accepted and integrated these into guidelines. Now, the preoperative fasting recommendations are 6 hours for solid food, some allows 4 hours for very light breakfast, and 2 hours for preoperative clear fluids. However, it is known and accepted and published that it is very difficult to limit the fasting process to 2 hours, especially for fluids, as surgery and surgical areas and procedures are very dynamic spaces and we use resources very carefully. So when there's a delay occurs or an emergency case arrives, the lists change very frequently and the surgeries and interventions get cancelled. Therefore, the fasting gets extended unnecessarily and prolonged over 24 hours in cases, 48 hours to 1 meal. And the fluid average fasting is published to be still today around 9 hours to 11 hours for all surgeries. Therefore, then in Scotland a few years ago, this more liberal fluid intake of septal sand, maybe you heard, has been taken on. And that allows patients to have clear fluids up until they've been called to TIRA or the procedure table. And it's been implemented quite successfully because I think the perioperative team members were ready for this change. and it was well received. Even in our pilot study where we were providing preoperative oral carbohydrates, not Ciptosan, so we were trying to use the 2 hours. It was still 9 hours, 2 to 9 hours differences between the fluid fasting. So what happens when patients fast this long is that not only they're uncomfortable, hangry, anxious, but they also are higher risk at delirium, postoperative delirium, and acute kidney injury and other postoperative delayed recovery period. And it also increases nausea and vomiting as well when patients are dehydrated. So 150 ml to 200 per hour for adults, 3 ml per kilogram for pediatric patients is allowed. This QR code is the ACI's website for Ciptosan. If you're interested, I'm happy to share the slides. Moving on really quickly for considering the time. Is it safe? So we know that the more clear fluids patients or people consume, the faster gastric emptying is, and less acidic the gastric residual volume is. And there is also less residual volume when people consume more clear fluids as well. And there are many studies comparing sort of type of the fluids if we mix some carbohydrates or some biscuits into them, and the gastric volume goes back to its original residual volume within an hour. If it's the sugar content is too high, it's an hour and a half, maximum 2 hours back to normal levels. This, I need to fix this slide, but just to give you an idea, the more sugar content, may be a little bit slower the emptying, but the average commercial juices that we have 4 to 6% of glucose, fructose, or mixed sugar content. So we expect them to be emptied pretty rapidly from the gastric space. The unpublished data from Tayside from our colleagues that we know 45,000 cases, 2/3 of them are emergency, only 6 regurgitation, only 1 extra night spent in the hospital, no morbidity occurred during Ciptosan process. This one is published, 11,500 patients with elective surgery having liberal fluids, clear fluids, and they, even though they didn't aim for it, they recorded significant reduction in nausea and vomiting, postoperative nausea and vomiting. Over 170 hospitals in Australia so far took on Ciptosan, implemented Ciptosan. The recent shortage in fluids, IV fluids, also convinced many more clinicians to join. So we are looking at currently collecting data on postoperative patient outcomes when we implement Ciptosan pre and post, and we will look into changes if they occur. We are also evaluating different implementation strategies in different hospitals and trying to look at that. We have consumer workshops to refine what exactly the patients prefer and what are their priorities and the information packages around Ciptosan, so as with the other key stakeholders, the clinicians. And in the future, we would like to look at RCTs in the different type of fluids and their carbohydrate content, and if that makes other differences in the patient outcomes. And we want to also develop the implementation sort of framework for other unwarranted, other old practices that we want to de-implement. And we also, with our systematic review, recorded severe heterogeneity in reporting perioperative patient outcomes. When nausea was reported, the opioids weren't mentioned, the antiemetics weren't mentioned, such as. So we want to also develop a standardized reporting sort of guidelines. These are a quick glimmer of the currently RPA allowed fluids and not allowed fluids. So patients are clear fluids. The ACI list also has the soup and the broth, I think, but we don't allow patients to have anything that has protein, fats, or starch content, that anything is going to slow down the passage from gastric space. Only carbohydrate drinks, some carbonated drinks, if the clinicians are comfortable with cordials and sports drinks like the electrolyte drinks, and not the energy drinks. They excluded absolutely. There were questions around what happens with for the patients with diabetes and IV fluids, and we always worked with clinicians and worked around with this. We didn't exclude diabetic patients. We didn't exclude GLP-1 medications such as Ozempic. They are also allowed to have liberal fluids. The challenges we face is that we basically, when implementing this, going against the existing policy of 2 hours, thank you. And some clinicians were really concerned about GLP medications. It was every sort of discipline adapted the intervention a bit, so conflicting instructions arised for patients. Some were instructed to stop at home, come to hospital, and then start drinking again. Some were allowed to drink all the time, so it was a bit confusing. And again, I mentioned the reporting, measuring issues. That's, I think, my slides. I think I lost a slide there, I'm not sure, but we want to look at the pre-procedural fasting, especially around sedation. Our clinicians are interested. So I invite everyone to please reach out. I would like to create this network, taking this opportunity to work with the angiography and other cardiovascular interventions and sedation fasting in the future. Thank you.
A really quick one from me, because I'm a big fan of the Coke Zero. So what's the suggestion?
Some clinicians were okay with it, and artificial sugar as well, because diabetic patients take diabetic artificial sugar included drinks. So
that's still considered as a clear food.
They weren't very happy about it, but we did include it, yes. No one wants to offer Coke to their patients, rightfully so, I guess.
Any other question? Yeah, please.
Seeing how this links back into say cardiovascular, does this impact on like dehydration levels and how blood pressure managed during operation?
We don't have the data. We want to look at it, not in the operation. We can look at post-operative data, but a really good point. We should maybe look into, especially cardiovascular surgery being too long and very heavily fluids very heavily managed. So I think we should look into it. Thank you.
Yeah, the question or any question online? Yeah.
I did a good job though.
Okay. Thanks again
Thank
for the
you.
presentation, Claria. Our next speaker is Laura Chong. She's a fourth-year PhD candidate in the cellular bioenergetic lab based at the VCCI, Chong Cardiac Research Institute. She completed a Bachelor of Medical Science, majoring in molecular biology, and a Bachelor of Science with honors at the University of New South Wales, Sydney. The honor project focused on the alterations to lipid metabolism in chemo resistant in the pancreatic cancer, and continuing to focus on lipid metabolism. Her PhD project now focus on understanding the alterations to lipid synthesis to cardiometabolic disease and developing novel compounds targeting sphenolipid metabolism for the treatment of such diseases. Okay, the stage is yours.
All right, thank you for that introduction. So today I'll be talking about the selective targeting of sphingolipid metabolism for the treatment of cardiometabolic diseases. So cardiometabolic disease is this grouping of diseases including heart disease, diabetes, as well as obesity. It is the leading cause of death, not just in Australia, but worldwide. We therefore need better interventions to try and tackle this health crisis. A shared characteristic in these diseases is the excess of lipid in the bloodstream that begins to then accumulate in tissues that are not designed for lipid storage. This then contributes to the metabolic dysfunction of the tissue itself. One of the lipids that we're really interested in is called ceramide, and this is a sphingolipid. So we can identify it by the shared motif, which is the sphingolipid base, shown in the gray up there. So there are a range of studies that have highlighted the overproduction of ceramides to type 2 diabetes, to fatty liver disease, as well as negative cardiovascular outcomes. Therefore, therapies that lower ceramides are of interest to try and prevent these cardiometabolic diseases. Ceramides are also known as the central molecule in lipid metabolism. There are multiple pathways in which it can be synthesized, including the de novo synthesis pathway and salvage pathway. But equally, there are these other pathways that use ceramides to create other lipid products. We're interested in targeting this enzyme called ceramide synthase, interacting in both the de novo synthesis pathway and salvage pathway. Notably, there are no available selective inhibitors for ceramide synthase available for use in humans. So we have developed this drug design pipeline using fingolimod, a TGA-approved treatment for multiple sclerosis, using this as a scaffold to then design and derive ceramide synthase-specific inhibitors. An example of this is P053 that was designed by our group in 2018. It is ceramide synthase 1 specific. It improves mitochondrial function and has anti-obesogenic effects. Using this same pipeline, we have derived a different compound called ET2.39, which will be the focus of the next 2 slides. And it differs ever so slightly from P053 by that chemical group attached to the benzyl tail highlighted in the blue. So we fed ET2.39 to mice on a high-fat diet, and we saw that with this treatment, there was a significant reduction in the endpoint body weight of these mice after 4 weeks. We did not observe any differences to lean mass nor the daily calorie intake, so this largely meant that the change in body weight was due to reduction in fat mass. So ET2.39, we also wanted to see how it might impact upon the accumulation of ceramides in various tissues. Highlighted here is the muscle where we looked at the levels of C18 ceramide. We're interested in this particular ceramide because it induces insulin resistance in skeletal muscle tissue. And importantly, our compound was able to significantly reduce this type of lipotoxic lipid in the skeletal muscle tissue. So some of the future directions we'd like to take with this research is to expand the program of therapies that we are developing and trying to improve upon the efficacy as well as gain additional selectivity to other metabolic tissues such as the heart and the liver. We would then upscale production of promising compounds to then test them in mice, but we also would like to interrogate how these compounds are actually interacting with these intracellular pools of sphingolipids. So very quickly, I'd like to thank everyone involved with the project. So my lab, the many technicians involved, as well as our collaborators at UNSW and the CVRN team for allowing me to speak today. Thank you.
Yeah, Alex.
Hi, cool job. Have you noticed any other changes to the mice's health? Any evidence of, say, rhabdomyolysis or muscle wasting?
So we don't see any difference to what the high-fat diet mice would typically lose. So it's not necessarily worse than your typical high-fat model, but that is something that we would kind of look out for in future drugs if they did do that. Obviously, that's not something we want to happen if these drugs need to be used in the long term on people as well.
Yeah, please.
Okay, thank you again for that talk. I know that with mouse models, they sometimes use genetic models of obesity as well. So would you expect to see the same sort of things in those OBOB mice?
I'm not sure. We are looking to eventually test in these genetic models. I guess one of the things that is to do with this particular high-fat diet model is that a lot of the carbon chains that are being put into the system are from the diet. So likelihood is it may or may not, depending on also the environmental conditions, but also, I mean, diabetes, obesity, it is a very multifaceted disease. It's not just the genetics, but also the contribution of the environment to the disease.
Yeah, Alex.
Thank you. You did a brilliant job of explaining what you're doing. Thank you, well done. What do you think is the mechanism by which causes weight loss or less weight gain? Like, is it appetite, are they eating less?
So we didn't see any differences in calorie intake. So they're all taking about the same amount of calories, irrespective if they're chow, high fat, or the treatment group also eating high fat diet. it likely would be due to, we actually measured the fat pad. So we know that the inguinal fat pad, which is probably the most dynamic of the fat pads with the mice, that was significantly decreased. So potentially the way that the fatty acyl chains are being used and absorbed within the tissue, that's contributing to some of it, but not everything is, the mechanisms aren't like purely defined yet. So it's still quite a bit of work to do on that.
Cool. In the interest of time, let's thank Laura again for the presentation. Great work. Our last speaker, but definitely not least, our very own Clara. So Clara did her PhD in the School of Biomedical Engineering here at UTS, specialized in bioengineering and advanced 3D in vitro models to study human heart pathophysiology. And her work includes developing the heart attack in a petri dish model and investigating drug-induced cardiotoxicity using patient-derived stem cells. She has also pioneered research on SCO particles, right? And demonstrating their protective role against the myocardial infarctions and drug-induced heart failure in both cells and mouse models. Clara's research extended to study the impact of SARS-CoV-2 on human heart pathophysiology and bioengineering models for preeclampsia-induced heart failure using patient-derived stem cells.
Thank you, Peter.
Today, Clara, we were talking about application of 3D cardiac in vitro models. Thanks.
Thank you, Peter. So, hi everyone. Thank you for the opportunity to present and for attending. So I'm doing more into basic research. So why animal models provide invaluable insight into understanding and identifying mechanisms which, for obvious reasons, we cannot study in humans. There's still the physiological difference between animal to human, but also human to human. So during my PhD, I have worked on mini heart, also known as cardiac spheroids, and that's because we need a complementary approach to understand and maximize the translation from the lab to the clinical aspect. So the mini heart is made up of the three common cell types in the heart. The cardiomyocytes is for the contractility of the heart, endothelium cells is for the blood vessel, and cardiac fibroblasts is to maintain the microenvironment, but also stick the heart together. So our model have shown to better mimic the molecular, cellular, and extracellular features of the human heart microenvironment. And we wanted to see, how can we use those mini hearts? And first, we took blood from pregnant women who had complications such as preeclampsia and hypertensive disorder. And those pregnant complication women can have cardiovascular disease down the line. So we wanted to see, what's going on with their blood. We isolated the plasma and added in the mini heart, and then look at the biomarkers in their blood. But also what we did is extracted their blood cells, made them into stem cells, and then make them their own mini heart to look at the function of the heart. Next, we look at how SARS-CoV-2, also known as COVID-19, impacts the mini heart. So back then, we couldn't really take patients' heart tissue to look at the effect of COVID. So that's why we tested the COVID-19 on the mini heart to know, how can COVID-19 affect our heart? And next, we try to mimic heart attack, also known as myocardial infarction, through changes of oxygen level. So with a myocardial infarction model, we also try to test a nanoparticle drugs that I collaborated with Baker Institute in Melbourne. So we look at how the protective effect of a nanoparticle on myocardial infarction. And the results have shown that the nanoparticle drugs significantly reduce the amount of dead cells, but also increase the level of live cells. And looking at the contractility of the mini heart, we see that the nanoparticle attenuate the reduction of the fractional shortening induced by myocardial infarction. So to translate our in vitro findings to in vivo, we tested the nanoparticle drugs on myocardial infarction mice, and the results have shown that while MI significantly increased the amount of fibrosis production, the nanoparticle drug seems to attenuate that production in the heart, but also looking at the ejection fraction, the nanoparticle significantly seems to attenuate the reduction in ejection fraction for those myocardial infarction mice. So to conclude, our mini heart can have a lot of applications, and of course, future direction needs to be done, but those mini heart can be used to minimize the animal use, but also in terms of patient viability. Thank you for listening. Oh, and I would like to acknowledge, thank you for everyone who supported me along the way, and also especially thanks to my PhD supervisor, Comine Gentili. Thank you.
Question? Yes, please.
That's really cool about the nanoparticle thing and how to prevent the cell death and myocardial infarction. What's the timeline? Like, does the as in if you apply the nanoparticle drug to the MI heart, like how soon do you have to do that to make that happen, or is that future work? I'm looking for like, can you apply this to humans?
Yes. So basically, it's still preliminary data, and we didn't do a lot of research about it. But the nanoparticle drug, we injected it before inducing the myocardial infarction. So the next step would be to induce the myocardial infarction and then add the drugs, which in most cases in human, that's what happened. But yeah, along the line, for sure, we would like to test after the myocardial infarction. Thank you.
Can you elaborate a little bit more on the nanoparticle? So where the nanoparticle goes, like subcellular or?
Yeah. So I'm not really in the field of nanoparticle. My field is cardiovascular. That's why we collaborated with people who does nanoparticle. But the nanoparticle we injected in the heart of the mice for it to be kept in the mice heart. And yeah, sorry, we haven't done into the heart, and then we inject
in the circulation.
No, in the heart, in the muscle heart, and then we did the ligation of the heart for myocardial infarction. So it's supposed to stay in the heart, but we haven't really looked at about the dispersion of the drug itself.
Okay, that's interesting. Any other question? Yeah, Alex.
Last quick one. I wanted to ask about the steroids. Do they contract? Or...
Yes, they contract. Sorry, I don't have a photo. I remove all my photos, but yeah, they do contract.
Okay, cool. I think it's time to wrap up. Please join me to thank all the speakers again for their presentation. Thank everyone here and online for staying here and listening to the talks. And please keep your eye on the Twitter account for future events. And I also would love to thank the CVRN team, Simon, Addison, and Marie for their hard work in the background. And please join us at the networking just next door in the kitchen. We're gonna have some flyers about the future events. And if you're interested in joining our team, please let us know. Yeah, and also please scan the QR code and give us some feedback. That's very important to us. And yeah, thank you. Please enjoy the networking. Thank you, everyone.